Once again, good morning. I'll be presenting operational research, the work that we conducted in a large ICCM program in Midwestern Uganda, where we assess the quality of care, particularly the clinical skills and then interpersonal skills. So my title is the assessment on communication and clinical skills of community health workers in rural Uganda. As an outline, I'll touch base on the background, provide objective of the study, the methodology, results, and some learning. As well as background, as there are increasing number of ICCM programs implemented in the world, and small scale and large scale, there is a need for us to focus on assessing the quality of care so that we are able to ensure that the children do receive appropriate care or management. But as often, when we look at quality of care, we normally focus on the clinical skills, and most times we will forget that communication skills or interpersonal skills do need also to be given or taken care of equally as the clinical skills. Good quality sick-child consultation should combine clinical and interpersonal communication skills, leading to a positive rapport between the child, the caregiver, and the community health worker. Disclosure by the caregiver of sufficient or relevant information on the diagnosis purpose, accurate clinical diagnosis, treatment, understanding the caregiver's understanding of the child's condition, and the commitment by the caregiver and the community to comply with the treatment and referral. This is very critical for quality of care. The objective of this operational research are the community health workers able to consistently apply the clinical guidance, that's looking at the clinical skills. What interpersonal communication skills are applied by the community health workers? Now there we're looking at the interpersonal care. The methodology, as I mentioned, this was a small operational research study which was conducted within a large-scale ICCM program implementation in Midwestern Uganda. We looked at one district, selected 20 community health workers purposefully. These 20 community health workers, they were from one particular area, so they had similar socio-economic characteristics. We used mixed methodologies, but mainly my presentation will focus on the qualitative one. We had direct observations, so the community health workers were observed. They were informed that we will be observing them. We are not going to do anything, but observing them to see what they are doing. We had at least 3 observations per community health worker. We never told them that we are going to drop the first one, but we dropped the first one when we started the analysis, because the first one we thought there would be fear, there would be tension between the community health worker and the observer. We had exit interviews with the caregivers. We had in-depth interview with the community health workers. In terms of the clinical skills, what we're mainly looking at, we're using the sick-child job aid. As Keria just mentioned, most of the sick-child job aid turned out to be their Bible or the book of reference for most of the consultations. In terms of interpersonal skills, we had a checklist, and we are really focusing on the 3 core competencies. 1, the social emotional care, diagnosis and problem solving, counseling, and education. This is the job aid that was developed in Uganda. This job aid was modified from the sick-child recording form that was developed by WHO and UNICEF. For Uganda, we decided to make it more simple, make it pictorial, easy to use, to replace the sick child recording form. We made it black and white to ease on the cost, and we laminated it. As basically, text at assessing the child, classifying that child, whether he has a danger sign or danger sign, do provide pre-referral treatment or treat that child at home, advise on treatment, but also we focus on routine care for the newborn because we want to integrate the routine care of the newborn into ICCM. But this is only for identification of those newborns that need to be referred for further management at a facility. So there was no treatment provided. I'm going to present some preliminary results based on those observations that we took. There was the strong technical skills observed in the community health workers. Most community health workers correctly apply technical skills. When we looked at the sick-child job aid to assess, classify, and treat, and are strongly guided by the sick-child, the use of the sick-child job aid. The job aid was used in all the 40 consultations. The job aid was used to even explain the test. I'm going to do a respiratory timer. I'm going to do the respiratory of a child. I'm going to do a rapid diagnostic test for malaria. So providing a conclusion, as well as treatment. Your child, since he's 2 years old, he will receive a particular dose of ACTs. And rapid diagnostic tests for malaria were systematically and properly used when assessing for malaria. This is what we found out in the technical skills. When we try to look at how well or correct diagnosis, treatment, information, or use of respiratory timer, and the choice of drug regimen, we try to see the assessment and the classifying. We found that where the community health worker had high suspicion for malaria, he would do a test. So all of them, they were able to know when to do a test. But when it came to situations like fever, if a caregiver has not mentioned fever, if he mentioned fever, some of them could be able to go ahead and ask for the duration. But in some situations, they will only stop on the fever, and they will not probe further into the duration. And we all know that the duration is very important, at least for Uganda case, to determine the cutoff between where they need to refer those ones to further to health facilities for further management. For example, any fever more than 7 days shouldn't be managed in the community because this should be something else other than malaria. It could be malaria, but could be also something else. Practices with scope for improvement. There was a tendency to work mainly from self-reported. They don't dig further to know, okay, if you present with fever, could this child also have cough? Could this child also have diarrhea, vomiting? So they could only self-reported. The tendency to work mainly on the self-reported. Tendency not to ask about the duration of the symptoms. I've just mentioned about that. Ask for the age of the child later in the consultation. Deviation from the guidelines was also observed, where the guidelines were not so clear, when and where to go if the child does not get better. The use of the respiratory timer remained a challenge. So because in the case for Uganda, we didn't have any specific job aid for the respiratory timer. In terms of the free core interpersonal competencies that we observed, caring and emotional support was evident. The rapport, which was exhibited between the caregiver and then the community health worker, this was so evident. This created credibility and the confidence in the caregivers for the services they are receiving. Counseling and education was present, but often limited to instruction giving. Your child will take this. So there was no negotiation and dialogue. Diagnosis and problem solving was weak. I really want to quote one community health worker. He said, "Alex, I'm sorry that you are not feeling well. Take heart. You'll be okay." This is one community health worker showing that he is caring to what he's doing and providing to the sick child. The example of social emotional care that we observed. These are just examples from there. The community health workers made body contact with the sick child, e.g., for example, touching. All of them. Some positive facial expressions. So, what is of partnership? So this shows you that they are really caring, and we shall see later towards the end how this becomes a driver for satisfaction. Example of counseling and education skills. As you could see here, as I mentioned, fewer community health workers were collecting misconceptions. They were asking caregivers to repeat or describe the treatment instructions. When are you supposed to take this drug? Discussion of follow-up visits. When your child gets worse, where to go? What do you need to do? So these, we think, are areas that deserve improvement. When we look at the main drivers for satisfaction, we thought that quality of care should lead to satisfaction. So we try to see how interpersonal skills and the clinical skills interplay to lead to satisfaction. On the caregiver side, being given a solution, having ICCM in your community, your neighbor being trained and able to manage your child when he gets sick, that was a driver to satisfaction. Caring attitude with the child, your neighbor or community health workers showing care and the emotional support he gives to your child when he gets sick was driving these caregivers. The use of the job aid shows honesty, that the community health worker who was trained for 6 days or a week is not thinking of getting all these answers from his head. He's able to follow the guidelines and uses that job aid to explain to you that your child, based on the results we are seeing, this child has poor malaria. I've done a rapid diagnostic test. He needs to get this treatment. This is how you are going to give it. I think Kerry has also mentioned it, that being the medicine they are using in the RSA facility is the one they are using in the community. So this one was a driver for satisfaction. What about the providers or the community health workers? Helping and solving a problem in your community is one of the drivers. When you talk about money, when you talk about retention, they will ask for an allowance, but the core motivator or satisfaction is being able to help solve a problem. A child who comes to you, imagine if your child gets sick, you go to a community health worker, the community health worker being able to manage your child, to find a problem that this child has malaria, is a driver for them to continue working. And gaining trust in the community. Use of the job aid to gain credibility. As we mentioned, that the caregivers, when they see the community health workers using the job aid, it's honest. And then also, it's a driver. I just want to give a quote from one community health worker who said that if you don't handle the child very well, the child will start crying. You will not be able to do a rapid diagnostic test. You will not be able to take the respiratory rate. The caregiver will be also disappointed in you. And in the process, they will not improve. But if you do well, this child will improve. They will always come back to you. They will always think that that community health worker is good. The learning. Sick Child Job Aid is a trusted guide for both community health workers and the caregiver, and appears to contribute to quality of care. interpersonal skills are the key drivers of caregiver satisfaction, impacting positively on the clinical skills. For this reason, joint focus on interpersonal and clinical skills can improve quality of care. Thank you very much.
Okay, thank you very much, James. Going to the chat room, Eleni, any questions? All right. Participants, any questions, clarifications, points? Teresa?
I know it's primarily a qualitative survey that we're doing, but you went through one slide very quickly, which was the part about them doing the clinical assessment and so forth, and how well they did that. And I just would like to get a better sense, because of the other reviews that I've been to, that how well they do as far as diagnosis of pneumonia. I know that that's been a little problematic in other areas of being able to count the respiratory rates and diagnose pneumonia appropriately and provide the treatment. So I was wondering, I mean, you went quickly through that slide, but maybe you can go back to that and tell me about it.
Okay, I think you could do that, but just to stress that Kirsty, who is presenting next, is actually going to deal with that topic specifically. So it might be worthwhile just to wait and we follow up on that question. Okay. Yes. Fine. Yeah. Not yet.
Thanks, James. It was really good presentation. A couple of questions. One, so you agree that when providers' practices are being observed, they change their practices, they change their behaviors. So I was wondering, did you triangulate those findings, or did you ask the recipients of care about their perceptions of quality of care provided to them? Secondly, wondering, were the caregivers or community members aware of their entitlements or aware of what to expect in terms of quality of care? Were they aware of what to receive or what they're entitled to receive? And thirdly, you talked about the providers and the caregivers, but I'm wondering, did you talk to children as well in terms of what their perceptions were, in terms of what the quality of care was? Did you assess child-friendly services, for example? Thanks.
I tried to pick much of your the questions from here. We never did exit interviews for the children. We thought these are under 5, so really digging deeper to find out their quality, whether to really assess quality of care from them would be relatively difficult. For the caregivers, as Keria mentioned, we had a strong community dialogues that are going on in these communities, so they knew what to expect from the community health workers. And the community health workers, one of the tasks or their roles before they start on actually taking care of sick children in their communities is to call a meeting where they discuss what they are going to provide to the community. What is the package? The medicines are for free. We have been trained. Here is my certificate. And we are supposed to do A, B, C, and we are supposed to refer those we can't manage. The coming presentation, I think, will touch on probably the referral aspects, whether they're willing to go or not. So we expect more to come from there. But yes, they were really aware of that. The other is the observation, whether it has a bias. I think James, maybe you will try to answer that one.
Yeah, I think with all qualitative studies, when you get to observations, it happens. You know that, and I think that's something which we did as much as we could to minimize it. And our approach was that if we could identify the practices that were good, it meant that you have the opportunity to help maintain those. Whereas those practices that were weak, with observations required a significant intervention, because otherwise you would expect them to change and improve. But I think also just to bring out the fact that one of the things that happens with research is that research potentially can contribute to improvements as well. And so we look at some of these things in a positive way, such that we can make a difference even with the research that we're doing. Any questions from the web?
Clarification. There's a question from Janet asking, is it expected that we have another job aid for community workers on sick children? So I've asked for a bit more clarification, so maybe I can get back to you.
Okay, maybe, yes. All right. Okay, Shay at the back, and then Prudence, and we move on to the next presentation. Oh, Henry, yes. So maybe Shay, Henry, then Prudence. Introduce yourself, please, if you don't mind.
Hi, I'm Shay Sremican from the London School. So that was a great talk, and it was just a quick point of clarification as well. You mentioned that when RDTs were used, they applied them correctly, but I just wanted to check, in the job aids that you showed, you flicked through them quite quickly, is there a step for RDTs in there? Because from what I remember, there wasn't, and I wondered if that would have an effect on how they're used in relation to the CHW knowing about fever, etc.
Okay, James?
Based on Malaria Consortium work that was done in Zambia, in Mozambique probably, in the health facility, we tried out the job aid to be used in the health facility. So that was already existing. So in our ICCM program, we used a similar job aid for RDT. So there is another job aid that used concurrently with the sick-child job aid. So this sick-child job, the RDT job aid is very clear on which steps you are supposed to do and supposed to carry. So whenever there is a need to do an RDT, they have a job aid to follow. But for the respiratory timer, they don't have a job aid to follow. So that's where I was mentioning. And I think the question from the people online, what was asking, so is there another job aid? Are you suggesting there should be another job aid? Or maybe there should be a job aid for the use of the respiratory timer. Or there should be another device that is easier to use to get the respiratory rate.
Yes, I think Henry. Henry, then Prudence.
Thank you very much. Mine is not a question. Actually, I would like to clarify on one of the slides that were presented, and I create context around it. On one of the slides, the observation of what the community health worker is able to provide at the household level, the ability to touch, give reassurance, explain exactly what is happening, what they have found out, and the kind of treatment they're supposed to give, and also listen in on the kind of questions that come, especially clarifying on how the drug should be administered, how frequently, and all. Now, that I will want to compare with the typical scenario that we have at the health facility. The actual situation in a health facility, especially in a high transmission month, like this one, in Uganda it's raining now. So we have a lot of malaria, we have a lot of pneumonia and diarrheal diseases at this time. The lines are very, very long. The number of clients that one single health worker has to see by the end of the day is very, very big. You're talking of 50 to 60 clients per day. So their ability to give the actual attention to all the clients that come is actually dependent on the workload. And when you go to lower level units, I'm talking about a health center 3 level or a health center 2 level. They are the ones that are closer to the community and they handle the biggest volumes, especially on communicable diseases. You find that the number of health workers manning a health facility are very few. And even their skills levels are very low. and their ability to accord enough time to explain is also limited by the workload. So these are some of the best practices that we should not ignore, especially when we have approaches that have been assessed at the community level. And that is where we would like to see more discussion on as Uganda. Thank you.
Thank you for that. Prudence? And then we'll go to the next presentation.
I wondered if you, in your 40 consultations, you encountered any patients who didn't have pneumonia, diarrhea or malaria, and how the caregivers perceived that and how the care worker dealt with that in advising the mother and in how to proceed, either to go to the health centre for further treatment or to manage a child with a sick child at home.
Okay, James?
I don't know whether this has to do with awareness in terms of the caregivers are aware of what can be managed within the communities. We never got any that they were not able to manage. When I mean managing, I don't mean that they were able to provide the treatment, but they were able to assess and then classify, because there were some that were referred to the nearby LSA facility. So we never received cases, for example, like a road traffic accident or things that are not manageable. So I don't know whether it was because of our awareness. I don't know which conditions are being managed at a community health level, but we never received such. Yep.
Okay, we'll go on to the next presentation. And just to stress that we'll come back to this issue of appropriateness of treatment even when we present the impact work. All right, Kirsty. She's going to present